Okay, welcome everybody to our November Community of Practice for the Rocky Mountain Employee Ownership Center. We are talking today with Dave Chase, who is a co-founder of Health Rosetta. This is a conversation that cuts in a lot of directions. Co-ops and social co-ops are very relevant to this conversation, as we'll hear a little bit later, how they fit into the big idea here. The big idea being to kind of take healthcare systems local, to open source them, to really kind of remake them in an amazing way by community-owned health plans. Who even thought that was possible? So in your invitation, you saw a little bit of the background on Dave Chase. I won't take time with that right now, but I'm going to turn it over to him. And Dave, we're looking forward to hearing what you have to say.
Yeah, no, I'm super excited about this and have been, a part of several of these. And as you know from our conversations, I think there's just a real natural fit. And I saw Mike Mercer on earlier, who's a champion of, cooperation amongst cooperatives and cross-sector. And I think this is actually a really good example. In fact, what you see in the backdrop on this slide are we give out awards every year for the best employee health plans in America. And you'll see we've got, a rural electric cooperative, a couple credit unions, and a grocery cooperative that is both a consumer-owned and worker-owned cooperative hybrid, which is pretty interesting. So as you can see with the title of the deck here, I really believe that cooperatives are really a natural leader in this transformation that, it's not a state secret that our healthcare system isn't performing real well. It was 11 months ago when there was some, crazy news, in New York. Nobody thinks that's a good solution to, take out insurance executives, but it did show how dissatisfied people are. And so we think that this is a really natural opportunity to bring in social cooperatives. I didn't know until I had had a conversation with Nathan Schneider about, because we always had envisioned this broad base of ownership. And he's like, hey, have you heard about this thing called social cooperatives? And so that led me down this path, which I'm really excited about. One thing, I am going to give a link at the end to this deck. So of course you're free to take notes as much as you want, but you will have a link to this deck. And so don't feel like you got to screenshot what's on here. Of course, you're free to do that too, but you'll have the full deck. And I will go through some things rather quickly, knowing you've got that as reference, and I'm really interested in the exchange at the end. So with that, I'll jump in. And so it's not always easy to explain what we're trying to do, and healthcare, of course, is quite complex. And so I like to use analogies and metaphors. And one I use is what happened a century ago. There was a market failure. Only 10% of rural Americans had electricity. Not long before that, it was even less. The investor-owned utilities like, oh, this isn't viable, possible. Obviously, the government stepped in, but to this day, right, the majority of the landmass of the U.S. is powered by rural electric cooperatives. And then today, you fast forward to another market failure where we're underperforming, we're overspending. In spite of that, 30% of all Americans are in debt to the healthcare system. That's 100 million people, like today. Most of those people had so-called insurance. And so at the end of the day, we realized a completely new system needed to be built. And so that's what we have been doing over the last 8 years, basically, since we officially launched. We've been working on it before, but I'll use one example from a community in Ohio called Ashtabula, Ohio, and very challenged community. And they were our first community-owned health plan, and there's probably 10 or so going now, but they were the first, and so we learned with them. And one of the guaranteed applause lines in a room full of clinicians as I say, healthcare is not expensive. You all only get 23 cents of every dollar, right? Most people think of healthcare as what clinicians do. And so everything from a medical assistant through physicians, every clinician in between, add 30% for benefits. Across America, it's 23 cents of every dollar. What's expensive is profiteering, price gouging hospitals, administrative bloat, fraud, and some inappropriate care. So this kind of breaks it down. Um, again, the clinicians, docs only get about 6 to 8 cents on any given procedure. So certainly we need other things, but we do not need, 77 cents of overhead. And so that's a lot of what we're doing is we recognize every community has a river of healthcare money flowing through it. The source of that river of healthcare money is all the people's pocketbooks in that community. It should work like a water cycle. Instead, there's these giant corporate pipelines that divert it to Wall Street and their water carriers. And so we just take back control of that. That is something that we can do. And it's important to recognize that if you look at actually what drives health outcomes, healthcare is part of it. It's about half of it's the actual care, half of it's access. It's about 20%, but it's health behaviors, it's social economic factors. The single biggest predictor of health outcomes in America is income and physical environment. Unfortunately, what's happened is we're spending close to 90% of the dollars on what's driving 10 to 20% of health outcomes. So our organization's purpose is capturing that waste, reinvesting it. It's been well documented for probably a decade or two, 30 to 50% of all healthcare spending is waste. We prove that every day. The best health plans in America literally can cost 30 to 50% less and provide far superior outcomes. Again, I'll keep moving through this, but you'll have access to this. And going back to that rural electric cooperative analogy, again, a lot of the same things present in rural cooperatives, then through today, and what we're doing with community health plans. They're owned by the communities they serve, keep resources and decisions local, balance community benefit, we don't have to reinvent things in every community. Elias mentioned that a big part of our theory of change is if we could prove thousands of times in companies, employers, large and small, private, public, rural, urban, thousands of times, it would be hard to say we got lucky over several years. And at that point, we would open source it. So we actually have a nonprofit called Nautilus Health Institute. I'll make a passing reference to that where we do that. And so all these communities can get that national learning and scale while having the essence of health. Health starts at home with mom and dad and fans out from there. It doesn't start with hospitals or carriers, right? Even though you'd think it's operated that way. And because of the fact that kind of an accident of history, 180 million Americans, 54% of the population get their healthcare through their job. The law that oversees it's called ERISA. It's an acronym passed during the Ford administration. You can pretty much do whatever you want as an employer. Most aren't doing good stuff, but we've tapped into that flexibility. There's some other legislation that through some kind of miracle, divine intervention, we've actually managed to succeed. And that's a whole other rabbit hole I could go down, but it's been very helpful for us. So we can do a lot of things that maybe historically people didn't think you could do. And we're doing it every day. And for this group, this is probably not new news, but when I read the report that Elias and team spearheaded, of course, I look at the world through the prism of healthcare, and it's like a lot of those social cooperatives were around care, whether it was elder care, disability care, those types of things, where even in relatively well-functioning nationalized healthcare systems, that's still a gap. And so we think that we can adapt, learn those lessons, but reflect the unique culture of our country right? A lot of ways we look like the EU in terms of different cultures, different values. One of the things I'm very gratified that we've been able to pull off is we are fiercely nonpartisan. We have extremely conservative people and extremely progressive and everything in between. And when it comes to a lot of these issues, like transparency, Marist did polling for a patient advocacy group that we're allied with. 94% of Americans believe there should be transparency on pricing in hospitals, as one example. Doesn't matter party, geography, age, gender, race, you name it, right? And we focus our energies on that common ground. And because of that, we've been able to make a ton of headway. And, from a cooperative principle standpoint, just go through the cooperative principles. Any employer can join this. Number one, employers, employees, and clinicians are governing these today. Obviously, as we build out, future stages of the development, because it's really early, the whole governance and thought process around that is an area that I think a lot of the best minds will need to come together on that. We don't claim to have figured all that out yet. But at this point, these are governed not by Wall Street objectives. These are driven by community objectives. In terms of economic participation, as I mentioned, the easiest and most direct thing to do to benefit members is stop 30 years of wage gains being stolen by healthcare, which is what's happened, and put the working and middle class in a 30-year-long economic depression, because 2 or more years of wage stagnation or decline are one definition of economic depressions, and that's what's happened. So we recycle that locally. The community decides how care delivery works and coverage, what's in the plan. I happen to live in a very progressive place. They're probably going to cover some different things than some of our friends in Alabama or wherever. And that's fine. We're okay with that. We have much of what we do is around education, training, accreditation. We have an annual event that has grown. We were coincidentally, given the Rocky Mountain Employee Ownership Center sponsors this. We were in Denver back in August. We had been there prior in 2022. We had 200 plus people there. This year we had 1,300 folks. So it's really growing, cuts across clinical leaders, employers, unions, benefit professionals, tech and solution companies. So that's a lot of what we do is education, including a lot of career switchers, by the way. There's both people who've been in this, but we have doctors, tech people, hospital CEOs, former White House senior policy advisors who've realized this is the best area to impact healthcare and in many ways society, since it's consumes so much of our budgets. 48% of the federal budget is consumed by healthcare. If you actually follow the dollars, Hopkins did a study on that. So if you're interested in that, I can send it to you. Certainly cooperation amongst cooperatives, as I shared in that screenshot, a bunch of cooperatives, even though we hadn't proactively pursued cooperatives, just by happenstance, cooperatives tend to care about their community, tend to care about their employees. And those are the people who tend to be the early adopters of what we're doing. And as I mentioned, our purpose is all about community and taking those dollars and recycling it. If you're interested in an incredible story, my TED Talk I did 9 years ago, still pretty applicable, other than the dollars have gone up. It's about a hotel company that I think when I did that talk, they'd save maybe $250 million compared against their benchmark, other hotel companies in Florida. Today, it's up to $570 million. And it's been great for their business. But the great thing is it's allowed them to not only have the best health plan in America for their employees, but fully fund college education for their employees' kids. And now 3 neighborhoods they've adopted, where if you graduate from high school, it's basically $250,000 that they give to fund that. That's the type of thing when you don't squander healthcare dollars, you can do that. We waste more than the equivalent of the entire Russian economy in our healthcare system. It's quite grotesque. So we want to put those dollars back into income, food, education, all that type of stuff. So if you look at status quo today, this is typical. An employer spending about $15,000 per employee per year. That's like 1.4 people because of dependents. A family of four premiums in the employer arena is $28,000, which is bonkers. And even with these high premiums, they have sky high deductibles. Most Americans are functionally, most employed Americans are functionally uninsured. Their deductibles are higher than their lifetime savings. And all while we're having extraordinary rates of misdiagnosis and preventable medical mistakes. I mean, if you dig into my story, kind of my radicalizing event was a friend of mine who got the wrong cancer diagnosis, and essentially the system destroyed her. And it wasn't there was a single bad doctor. It is our system. And 1 out of 5 times when you get a cancer diagnosis, it's just flat wrong. And then even if it's right, 40, 50% of the time, you're not getting the latest plan. So we might not be able to prevent a cancer in the short term, but we can certainly put people on the right path. And so the impact has been devastating. This data is quite old now. This was actually run right before the 2016 election. If you have wage gain stolen for 20, 30 years, dollars got to come out of somewhere. It's not coming out of, vacations, the Bahamas. It's coming out of very core stuff. It's quite brutal. I've wallowed in this graph here hundreds of times, just thinking about the pain that's being inflicted on the average American. This was about the middle class, middle income folks. Fortunately, it's a whole different story in this new healthcare economy that's already bigger than the US video game industry. Of course, it's not nearly as big as the healthcare industry, but dramatically lower spending. There's no reason to have cost sharing for things that work, like primary care, appropriate medications. We have people who can help you navigate to, the Mayo Clinic for a second opinion and care there as well. It's worth, even if they're not the cheapest, they're the best for many things. These are the types of things that are very straightforward. We didn't claim to have invented anything. We're all about how do you replicate what's been working. And so, I joke that, I was an archaeologist digging around for healthcare's Rosetta Stone. These people had kind of cracked this indecipherable code. And now I'm Johnny Appleseed, just kind of spreading the word. And so these are the things that people are doing today. Employers are doing today, funding college education, adding back dependent coverage, which used to be pretty standard in health plans, funding home solar, unprecedented bonuses and raises, subsidizing healthy food, let food be thy medicine, as Hippocrates said, fund daycare. These are the types of things that are possible when you don't squander money. In terms of how do we actually build these things, obviously it's hard work to do this. We don't want to have to organize the Roman legions to get everybody together on the same page today. If you look at Ashtabula, Ohio, all of those employers are operating independent of each other, but all on the same chassis. It's like when for some of us old tech folks, like back in the day, there were standalone PCs that had this internet protocol called TCP/IP. Once the World Wide Web came along, that's one of the things why it exploded. And so as employers, they can operate independently, but they get the economies of scale of the same contracts for primary care, hospitals, imaging, concierge navigation, and it can start very small. It started with a single employer with 38 employees. This is not Walmart. So that's another misconception. You got to be giant to do something here. It's just simply not true. And then over time, we can mesh more and more of this together. And then as you get into 5 and 6, that's where hopefully we'll all work together to work out some of the details. But we have a pretty clear roadmap in terms of how we think this, at the end of the day, becomes kind of like that rural electric cooperative, a community-owned health plan utility owned by that community that it serves. And that's a really key thing. So you can get benefits at each phase. You don't have to do everything all at once. Some organizations are being conservative and just do one of the 5 steps that we have in kind of this transformation. That's totally fine. We can meet people where they're at. And just to give you a few examples, Ashtabula area schools, this is a school district quite small, 8th poorest county in Ohio. And they put in a plan, thankfully, about 10 to 11 months before a school levy failed in May of 2021. Even though it only been 10, 11 months, they'd saved more money than the entire school levy and avoided disaster. They would have had to cut teachers, programs, benefits, transportation, and this really spread word of mouth in that community. That's one of the benefits of public sector employers is they're kind of slow to move, but then they're very influential. Pacific Steel and Recycling a decade ago was spending $8 million for their 700 employees. By the way, they're an ESOP. And they improved their benefits, got rid of cost sharing, had direct contract, cut out middleman, and cut their spending by more than half. They've gone, I think, 4 to 5 years at that $3.5 to $4 million per year spend level, while their peers over that decade have gone up to about $12 million. And so you can imagine what that has meant for the value of those shares for these, ESOP folks. They're a 130-year-old company, slow growth, low margin. The CFO said they would have had to increase top line sales revenue 25 to 30% to have the same impact. You had people's nest egg basically double as a result of that. Rosen Hotels, I mentioned that story. I got a TED Talk case study, so I won't go through in detail. But at the end of the day, today, healthcare is the #1 driver of wage stagnation, debt, and bankruptcy. We're the undisputed world leaders in medical bill-driven bankruptcy. 70% of those people had so-called insurance. Again, that's a choice we're making, and we opt out of that. If every employer did this, this would be like a recurring $500 billion stimulus into our economy. This just breaks it down a little bit of how these kind of seeds are planted in that particular community of 100,000 people in that county, a medical desert. Again, a lot of what you would consider stereotypical Rust Belt challenges. And despite that, years later, now the school's sitting on a significant surplus. Okay, what do we do with all this extra money? Do we subsidize healthy food, early childhood education, whatever? Now they've got those options. The medical desert's being addressed. And it's a single hospital town, kind of a bully. Their tone has really changed because we just steered, their quality's not great. And so we just steered care away. Most people, if you give them the option, say, hey, you might have to drive an hour, to get this procedure, but you'll pay exactly zero, versus another scenario, we had a $5,000 deductible and you're going to have severe financial pain. Most people will happily drive an hour. And that clinic got so much business that they've actually opened an outpost in that area. So we're addressing some of that medical desert dynamic. It's great for the employers. It's helped them with recruiting and retention. The school district, they compete with more affluent Cleveland suburbs. They actually had a teacher leave who then came back because oh my gosh, I was paid more, but my health care premiums were so much more. I was upside down. And so even this, low income school district is able to compete for that. And so it's really nice throughout this. We're getting this immediate benefit while we're working on this really tough systemic problem. Great for the employees, right? They get the best access to the best surgery center in the state. They have 7/24 direct primary care. Medications are free when they go to the community pharmacist. So it's one teacher said, I think they had a $200 to $300 copay on a life-saving medication that this was all of a sudden they showed up at the pharmacy and it was $0. This was a significant raise that I got. And then in terms of the community, we've certainly helped that school district a lot. Economic development, I'm going to expand on that in just a moment. And as I mentioned, the medical desert is being rectified. And so we're not out of the woods. There's lots of tough challenges ahead, but we've come a long ways. And if you look from an economic development standpoint, you could throw all the tax breaks in the book at a company to attract or retain them. They do not measure up to if you're a high value community, and those dollars are recirculating over and over and over rather than going off to keep Wall Street happy. So it's a different framing around economic development. My own community, I've just been engaging with our economic development group, and it's very eye-opening for people to think about it that way, but it's a useful framing. Um, I gave a keynote that I'm not going to redo here at our event. I've got a link here. I've got a link to the deck we're going to share later. But basically, I had this framing of there's very solid research suggesting how much displacement of workers there's going to be over the next decade. And I think the need to change things for that, but also healthcare is a nice intersection. So I just am doing a major rewrite of my last book, Relocalizing Health, and I do this framing where AI can either be a tax that really burdens a community or a catalyst. And so you can watch my keynote, just 15 minutes long, but it kind of gets at that. And if you want a draft in my chapter, I think if you get access to the deck, I think in the speaker notes there's a link, but if you don't get it, you can look at that draft. And I really believe communities with social cooperatives will choose this AI catalyst. How do we deal with this situation for good or bad? And let's obviously make it for good. And that's what I think these communities will do. Let's just expand on one of the cooperatives I mentioned. This is a grocery store, 4 locations. They totally change their health benefits. They have home visit, direct primary care. They have support for nutrition and integrative health. And again, a lot of what we have in our blueprint is saving that organization and the individuals tremendously, and it's helping them attract and retain talent as well. And we just have found there's just this real natural fit between cooperatives like grocery cooperatives, but certainly credit unions, because they touch so many people in the community and, for a bunch of other reasons. And so it's been gratifying to see how many of them are already coming on board. There's also, with large employers, there's actually a purchasing cooperative called the Health Transformation Alliance that has come together and is making a dent. So again, another example where there's this kind of cooperative spirit. A lot of times cooperatives rise when there's a particular challenge a community is facing, and we certainly have that. So there's some great impact there. Their chief strategy officer is a member of our program, and he was one of these benefit broker, benefit advisor, benefit consultants are basically like the insurance agent who goes to the company, helps them decide on what plan. He was a part of our program and learned about that, and he was recruited away from one of the benefit consulting firms and has really imbued his strategy into what they're doing, and they're a nice collaborator on this. In my keynote, I talked about for every 100,000 person community, there's about $450 million of waste. And if we're smart about it, we can redirect that into the types of roles that make our communities special, right? Whether it's there's healthcare related stuff and health related stuff, but you think about what makes our communities special, right? It's the culture, it's the recreation, it's the restaurants, these types of things. And that's some of what I go through in that chapter. I think Elias was involved in the translation of the Reflections book. I brought in some of those quotes, and he just, it was just like, the Stoics or Proverbs, wisdom literature, reading that. So definitely brought in that. And in terms of our ecosystem, there's a few options. You want to learn, come to our annual event. That's going to be at the end of July. That's where we're celebrating the successes as well as learning from others. NautilusHealth.org is this open source resource where we take our most proven intellectual property for people who want to, you wouldn't think health insurance would be the area of impact. There's few areas where you can have a bigger impact on a community than doing that. That's why we've had so many career switchers. come into this, and people who like literally square one, now they're, kind of lapping people who've been in it in a while because they didn't have to unlearn stuff. And so we've had people like that. Or more likely, you're connected, you're employed, you're a leader, tap one of the people in our community to help your organization. We started doing this when we had 5 employees. You don't have to be huge to do this. Of course, you don't have as many options as the big guys. In some states, it's harder, but it's not an excuse if you're a small employer. We have a lot of tools and things are getting built out. I think I have a map coming up. You can see where some of them are. Um, haven't thought as much about this. I think you probably have all thought about this more, but I gave a little thought to what are some of the policy and regulatory things that would be helpful. Have a few lists. Um, I coined this term Community Health Self-Determination Act, taking a page out of the Indian Self-Determination Act. One of the inspiring stories for us early on was a community in South Central Alaska, Alaska Native peoples. Incredible story. Again, really challenging scenario. And I think there's a lot to be learned from that we could do to take back control of our system. And again, some of the calls to action to people who are, in the cooperative community, every employer is in the healthcare business, whether they like it or not. And if you are anywhere around that decision right now, it's just horrific increases, some of the worst ever. And it's not justified, but it is happening. And so we can help people out right away. And then sharing that success within your community. That's how these things grow. It started, I think it was a chemical company in Ashtabula, or auto dealer, one of the two, before it went to the public sector. And so I'm trying to do that in my own community to get it going here. I mentioned RosettaFest. You can join our, go to healthrosetta.org. You can learn more about what we're doing, engage with us, and certainly on the policy front, we need to put our heads together. And I think it's really a great avenue to build democracy skills, right? We need more democracy skills right now. And there's a group of us in my own community where like, how do we bring cooperatives in? And one of the advantages of healthcare is everybody's impacted by healthcare, every business. And so even though it's complex and challenging, it does touch everybody. So it's a great way to show people, hey, we don't have to depend on some folks in a boardroom in Minneapolis or Hartford, Connecticut to take control of this. These are some of our initial community-owned health plans that are getting built out right now. Hopefully, we'll put a lot more pins on the map. Just actually got an email from a guy in Annapolis, Maryland. He's like, he's just like just joined our program and he's just like ready to hit pedal the metal. Had a group last week that they're really leaders in the maternal health journey, bringing the best system in the world out of Brazil back to the US. And they want to get going in a place in South Carolina and a place in Arkansas. We're great. We're ready to help out. And so I'll wrap up with this great quote by Father Jose Maria. World has not been given to us to contemplate, but to transform. And it is absolutely in our power to do it. I hope you'll join. Here is the link to this deck. And so you'll have it. There's some other slides after this that go into a little more detail on community-owned health plans, but I already went a little longer than I was hoping. So I'm going to stop my screen share and really look forward to the questions. The harder, the better. I welcome rude, tough questions as long as they're in the spirit of solving the problem. So, Elias, you take us from here.
Okay. Wow. Then it's just mind-bending, isn't it? This is just like, it's like discovering oil or something. It was there all the time. We just didn't know how to get it out. Yeah, I'm going to put one quick question out, and then you folks chime in. I just want to ask this. There is a big hand-holding process here. I take it, if you're going to go to a school board or a hotel system or whatever, and you're going to say to them, you guys are going to pull the plug. You're going to pull the plug on Blue Cross Blue Shield. Like, what? And so I'd like to know, what is the timeline in terms of where the plug gets pulled? What do you have to build before that moment? Because it seems like it's going to be a real journey to kind of get there. But how quickly can that happen? Is it something you can do maybe more quickly than we might expect? Or what would your thoughts be?
Yeah. No, it's a great question. We have in the back of my last book, Relocalizing Health, I have a acrostic that spells local, and the first step is leave behind status quo mindset, and that's by far the biggest obstacle. A lot of people think, gosh, if I show up at a dock and it doesn't have this fancy national logo, I can't get in, and that's not true, but they think that. And so in terms of the time frame, and 4 of those 5 steps are invisible to the member or a clear positive. It's only the last one that actually is the biggest benefit, but requires the most thoughtful communication. And you can have a great plan design, but if you haven't communicated it very effectively and done the change management, it will still fall on its face. We see a few ways people do that. There are a small group, probably 10 to 15%, that want to rip off the Band-Aid. They're at their wits' end. They're like, and ideally they are in a high trust environment with their workforce, and they're going to rip off the Band-Aid and completely cut over. It can be done. It's not necessarily what we recommend, but it can be done. There's another group that says we're going to take it a step at a time, and we're going to, depend on how big we are. I'd say most organizations, it's a 2 to 3 year period where they go through these steps. The bigger they are, it tends to lengthen it. If they're small, they tend to be quicker. And they're basically replacing step by step. I have a case study in my book, Copper State. They're a manufacturer. They just cleaned up the contracts. The second step is all about this really boring stuff of changing the contracts. And because we found that 95% of employers treat all these contracts that make up a health plan like I treat terms of service on some consumer website. A check, I agree, but they've given the industry a blank check. And they found $1,000 per employee per year of savings. They had 1,000 people. So boom, that was $1 million kind of before they did anything. But that's the master key that unlocks the other door. And then the first thing that starts to touch care, that's the lowest hanging fruit, and is actually the most common touch point with the healthcare system, is the C in local, is carve out PBM. PBM are these crazy companies most normal people have never heard of. They're some of the biggest companies in the world. They actually make more money in many cases per drug sold than the pharmaceutical companies, if you can believe that. Fortunately, there's good PBMs. And so that can be a place that they can start. And so, and then they might use the dollars saved there to fund primary care. And that's the first thing that they definitely notice, because on the PBM, you don't necessarily even have to change the formulary where people pick up the medications, though there's a lot of opportunity there. And then the last piece is redoing the networks with the hospitals and imaging centers, and again, the biggest benefit to the member, like the example I gave, where you're paying zero for what you had huge out of pocket before, but you definitely have to redo contracting and whatnot. So generally 2 to 3 years. And again, it depends on the culture and the trust and change management, but that's usually what it does. But you got to start with just an assessment. We have this thing called a plan grader. It scores the existing plan, and that starts the education process. Like, gosh, I thought I had as good as it gets, and you're telling me, which most status quo plans get a 5 to a 17 out of 100. Yes, these things aren't a fantasy that are going on here. There are companies with a 90. That starts to open their eyes, like, oh, I didn't think that was available to a company my size. Well, you're not getting good information. So that's the response there.
Cool. That's good. Nicole has a question.
Yeah, thank you so much. And I'm sorry, I have a storm here, so my tech was cutting out and I missed the first few minutes. I'm still processing how this couldn't be too good to be true. But my
Yes.
thank you. Thank you
Hi.
so much. My mind is wondering how much in order to kind of seed or get the people on board as like the leaders to drive the process. What comes to mind is in tribal, I guess in tribal communities, do you find that there's any room, or is it just too large of a barrier with the Indian health system, the IHS program? And then also within healthcare workers, is it actually like people who are on union boards for their units, or like where would you see a foot in the door more quickly? Thank you.
Yeah, there's both great examples. And one, I mentioned the NUCA model. If you go to SCF as a South Central Foundation, NUCA, NUKA.org. This is an unbelievable story. It's part of the Indian Self-Determination Act. So there's definitely an opportunity with tribes. What they did was kind of the full meal deal. There's also tribes that are employers of casinos and whatnot. And so there's certainly an opportunity there. And we do have some advisors who are focused there, but it is a bigger lift. Unions, again, bigger lift, but some of the best success stories are there. One of the ones in my first book was the consortium of school district, and union leaders basically around Pittsburgh. And then there's a SEIU union in New York that's doing incredible stuff right now. And so again, it's union dynamics, so you need to get people on board and all that. So it is an incredible opportunity there. Healthcare workers, for sure, healthcare organizations, they're employers, and the hospitals are usually the largest employers. And we do have winners of the Rosie Awards, which is our award for the best health plans. And if I'm talking to a hospital CEO, hey, this is a great way to develop these new muscles for your own employees before you roll it out to the rest of the community. And certainly they're really influential if they're part of these community-owned health plans. And some of them, they've been an anchor partners. It tends to be more the community hospitals versus the big health systems. And they tend to be the most allied, and the public hospital districts are a really great opportunity. And rural hospitals, we have DeSoto Memorial in Florida has a great story. So we've really seen successes in just about every industry, but the lower margin they are, the more their workforce is working middle class, the more they feel the pain of the current system. So we don't have a lot of the Facebooks and, hedge funds and folks like that. It tends to be, during COVID times, we call their workforce essential workers. That tends to be the most common early adopters. And I totally appreciate the too good to be true. I would have said, somebody said to me what I was saying 7 years ago, 8 years ago, I said, good luck, pal. Call me back in 5 years and show me. And so that's part of the reason we have the Rosie Awards, which you go to healthrosetta.org/Rosies. You can see some of the different organizations that have won. My books, we've got tons of case studies. Fortunately, we've got thousands of successes now. So, each has its own set of challenges. Each geography has its own set of challenges, but if you want to do it, it's absolutely possible.
Looks like Jay has a question. Jay?
Yeah, thanks, Dave. This has really been super interesting. I'm curious if you had mentioned, health deserts in places like in Ohio there. So maybe competitors aren't even there to really be responding, or how they're acting, I guess, in the face of this different model. Can you speak to that at all? And I also think you mentioned a really great phrase of radical transparency, which to me makes it seem like a little less you're not hiding things to anybody, I think so. I think that like provides a pedestal even to stand on, so that might take care of some of that. But yeah, I'm just curious about competition in this area.
Yeah, I mean, if you look at where we've had the most early traction, in this first decade, it goes beyond this, but beyond the sort of sectors and whatnot, I would say size of organization, it's probably been 80%, 50 to 5,000 employees. If you drew a ring around major metro areas and went from about 45 minutes out to 2 hours out, that would probably be the most common geography. Um, and it's not the most defended turf, as you alluded to. And so there's no benefit to us to go poke the bear. We're not against anybody. We're for something great. And so I would say to the extent they know about us, they probably just think we're an ankle biter that they can just kick away. And, we're just idiots yelling at the internet. And the longer they think that, the better. And we try to tell some of the people in our community, like, you know, don't go poke the bear. But that's why, as I looked at this grand challenge, when I really started this journey, I looked at it as the scale of things like women's suffrage and civil rights, that the things that are really huge lifts, they don't have a prayer of success without a grassroots long-term movement. Um, and so I think that's one of our biggest gaps. And one of the reasons I'm excited about working with cooperatives is they're sort of inherently kind of community organizers and community oriented. We can do the blocking and tackling of health plans. We have a lot to learn in terms of community organizing. And that will be like, if you look in Ashtabula, the fear, uncertainty, and doubt that incumbents always use, or politicization, right, to freeze status quo, it stops working when people can see it with their own eyes. And so that's what's happening. And like with the 900-pound gorilla in Ashtabula, they're very entitled, and were problematic, and probably very dismissive to the people on the ground there. Now they're like, oh my God, these employers, and now the school district, the city, the county, they're all like, we just built this big facility. We're hosed. And so we don't want the master slave relationship to flip and we're the master and they're the slave. We just want a fair deal. And when we get a fair deal, we'll work with you. But we're also not going to be bullied. And most people are willing to drive if they have to, for stuff. And there are a lot of places where we have medical deserts and West Virginia lumber mill, right? There's not a grocery store within an hour, but we'll get a primary care doc to go there a couple days a week or a couple days a month, and then they can have the relationship remote. And like, there's always ways around those problems. Some are tougher than others. But yeah, we really think the grassroots movement is the way we contend with the attacks that will come, which for the most part, they haven't yet, because it's the jumbo employers that are the most defended turf, but that's only about a third of the workforce are jumbo employers. So the mid-market's really where it's at.
Great. Dave, I got a question about the thing I was kind of like the minimum viable ecosystem. And I want you to tell me if I'm approximately got this right, or straighten me out if I don't. If I wanted to do this right now in my town, I need to go find, in addition to partnering up with Health Rosetta for the advice, I also need at least one primary care physician. I need a nurse navigator. And if I understand correctly, I believe I need ideally an independent pharmacy. Those are maybe not so easy to find anymore. Is that sort of the bare bones, or could you give us a little more of like what's the minimum blueprint?
Yeah. It's interesting. All those things we definitely advocate for and are important. But if you look at the Pacific Steel, they had none of that. They hadn't done primary care. They had a member champion. It wasn't a nurse. So that they kind of had that piece. And to my knowledge, they didn't partner with any particular community pharmacy because they're in 44 locations in 9 different states for only 700 employees. So that wasn't as much of a linchpin there. And so even in that scenario, you could do a lot. Now, is that going to really be a community-owned health plan? It's, it's about 250,000 people in our county. And I think to really, get this really going, In the first couple years, it would be really nice to have 1,000 employee lives. We're going live with the first employer, 1-1, and I think they have about 200 employees. But there's probably another 2,000 or so across a few construction companies, a regional coffee chain, and then the city here. And they'll come on at different paces, hopefully. So far superior if you have the primary care and the nurse navigator. That is really super helpful, but it's not necessary to get going.
Okay, great. Okay, Alyssa has a question.
Thank you. This has been amazing to hear about, and so I'm looking forward to getting all your books and checking them out. But I'm really thinking about this from another perspective, which may what you're describing. But in America, we have such a terrible investment in mental health. And my interests right now are kind of at this intersection. We have a huge number, I'm in California, we have a huge number of community land trusts, right? So community ownership of real estate. But then from the mental health perspective, a place where I've been working recently, I've worked for them in the past, they are a licensed residential facility. There are people who have serious mental illness, who need help with their daily living for one reason or another. They can't live with their families. And so you need a licensed facility. You need real estate. You need people helping them day to day, giving medications. And so I guess I just wanted to kind of ask your insights about how this applies to the world of mental health, and also maybe flag, I would just love to learn more and see if there's ways we can bring this to the community land trusts here in California, because all of them are tiny organizations. They're having to pay whatever, to get regular healthcare, provide healthcare to their employees. And the cooperative sentiment is strong, right? The cooperative values are strong in this particular group. And so I just want to flag that I would love to, in any way I can, help connect you and drive something here.
Yeah. And by the way, my email is just dave@healthrosetta.org for anybody who wants to contact me. And I'm very available on LinkedIn as well. Mental health is a really key issue. Interesting. I don't know if you heard this news last week. It was the first time that there were more mental health visits than primary care visits in the last year, which both speaks to the scale of the challenge, but also we've undermined primary care. And I'm not a behavioral health expert, but it's of course a super important area. One of the framing that was helpful for me was, if you look at the range of mental health, there's things that really can be addressed in a primary care setting. And then there's specialists, just like, if you have an orthopedic issue, there's a lot that can be addressed in a good primary care setting, but at a certain point you need PTs and you need orthopedic surgeons, and so knowing like what slice of it you're going to take about. And the piece you talked about is like literally inpatient site cases, right? That is, the equivalent of, getting, cancer or something like that. So obviously you got to address that, but each of those kind of has different modalities that are most effective. And, we have to chip away at that. The other thing that doesn't mean, definitely the last thing I want to do is diminish any of it or oversimplify it. But I do believe that for me, March 9th, 2016 was this big moment of awakening. For me, it was I woke up to the news that Bernie and Trump had won the Michigan primary, and I was kind of like, what is going on? And that's kind of when I started connecting the dots and go, okay, you have more than half of adults in economic depression that's 25 years long. Some crazy stuff's going to happen. That's way longer than 1930s Germany or a Great Depression. And so I believe a very significant part of our mental health challenges is when you put people under duress for that long. I'm relatively privileged. I have, a bad stock market day and it stresses me out. Like I'm not on the cusp of homelessness because of healthcare bills or bankruptcy. And so, again, that's not the totality of the issue, but I think we should be sober about how deep the pain that's been inflicted by our healthcare system has been.
And I'm going
Yeah,
to
and
I'm going to insert myself right there because I have a hard stop on the hour. And in a sense, as practitioners in this space over decades, over generations, over the last few weeks or years, as impromptu artists, we get to create this space to say yes and to then try to make the care available for others to come and to continue this practice. So I sent you a link. We'll be in touch. I'm sorry, but my meetings now this morning are about this. So many blessings with you all, and I love the art and the care you're all taking. Thank you so much.
Thanks, Remy. Good to see you. And Alyssa, if you guys start a conversation about the CLTs in California and partnering up, I want to keep up with you. I think that's a great idea.
Yeah,
Okay.
totally. Yeah, I'd love to see what can be done there. Your state and my state, which is Washington, happen to be two of the most challenging states with doing things, but still good stuff's happening in both.
Awesome. Awesome. All right. Anybody else want to jump in before we close up? What a great conversation. This has been fantastic, and I'm glad we recorded it. We're going to put it on our YouTube channel and all of that. It's also a subject we're going to be coming back to, of course, as we kind of oscillate between stuff that's a little bit more narrowly focused on social co-ops, and then we're also talking about the social economy in a way, which is a whole different, bigger framing, more like the way people talk in Europe and so on. So if no other final thoughts, anybody? Last chance. Dave, thank you so much.
Yeah, thank you for the opportunity.
And thank you to all you folks. We'll be back. Stay safe, stay well.
Thank you.
Ciao, everybody.